Now, a full-term pregnancy lasts for about 40 weeks, and any labor or any labor contractions coming before the 37th week, then it's termed as preterm labor, and a child born before the 37th week is a preterm child or a preterm baby. Now, today on the show, we want to have a look at some childbirth complications. We'll be looking at what exactly happens and who is at a risk of getting the complications during delivery, and how is the child affected, how is the mother affected. In studio, we have special guests. We have Dr. Edward Sang, a gynecologist, and also Charles Muriuki. Both of them are experts who will be taking us through some of the possible complications there are. Feel free to call us live and ask us a few questions. The number will be displayed at the bottom of your screen, and also you can use our Twitter handle, which is at Ebru TV Kenya, and at Purity 478990 to call us live and ask us a few questions. We are live, and in studio we have two special guests to just help us understand some of the complications there are, and how do you tell that you might have childbirth complications? Who is at a risk of having complications during delivery? Those are the questions we'll be answering in the next 1 hour. My name is Purity Museo, and you are right on time for my doctor show. Now, help me welcome our special guest. Seated next to me is Dr. Charles Muriuki, a gynecologist, and next to him is also another expert gynecologist. His name is Dr. Edward Sang. Welcome, both of you, to the show, and thank you so much for gracing us with your presence. We appreciate it. Yes, and allow me to begin with you, Dr. Charles Muriuki. When we talk about childbirth complications, do we have an ideal definition for this, or when do I know that this is a complication? As doctors, when do you term a delivery a complicated one?
Thank you. So I think childbirth complications are, in a very simple way, anything that deviates from the normal. Because as we've heard from the video, the delivery usually should follow stage 1, 2, and 3. So anything that would not follow that pattern would be considered as a complication. But I think it's important to probably say from the outset that we should ask ourselves who is at risk and who is not at risk. Because that would be the best way to be able to say, how do we then manage the labor for somebody who is at a high risk and somebody who is at a low risk? Right.
Yes. All right. And you've introduced the issue of normal delivery. I know it's been explained, the labor process, but maybe Dr. Sang, in a layman's language, just help us understand what's normal when it comes to delivery.
Usually, the labor shouldn't take too long. The baby should be born within a certain time. And the placenta should also be extracted within a certain time. The blood loss should not be too much. We should not have too much injuries, too many injuries to the mother, like to the rectum or to the urethra or the vagina. So everything should be within what Dr. Muriuki is saying, the normal parameters that we expect. And so if it deviates from that, if it's taking too long, or even too short, actually, it shouldn't be too short, it shouldn't be too long, and there shouldn't be injuries. And then, of course, the baby should be well, should come out and score well and alive.
All right.
And if the baby is not okay, again, that's a complication.
And Doc, just tell us, when you talk about not too long, not too short duration, what exactly are we talking about? Do we have specific hours that labor should not maybe go past that? Do we have minimum and maximum labor hours, if you would explain that as well?
So usually they say when a lady comes in labor, the cervix generally should dilate about 1 centimeter per hour at a minimum. So if it takes longer than that, so we expect about 10 hours if the cervix is completely closed, because it is fully dilated at 10 centimeters. So if it goes past that, then that's a bit too long. On the other side, we also don't want it to be too short. So there are those ladies who the progress is just too quick, and that is risky because there might be injuries and there might be bleeding problems. So there's just that 1 centimeter per hour.
Yeah. And okay, Dr. Charles, when you talk about childbirth complications, are these child-related complications? Do we say they are the mother-to-be related complications, or are there complications that both of them could have? maybe can we categorize them?
Yes, so when we have a lady in labor, basically we know, much as we see the mother in labor, we know that there are two patients.
Yeah.
There is the mother and the baby. And ideally, there should be a way to know, is this mother at risk of a childbirth complication? And when you talk about childbirth complication, we're talking about any deviation from what we expect a normal labor to be. And is the baby at a risk of a complication, and mainly maybe stress during the labor process? And this also has to be factored in initially, so that at the end of it all, what we say is that there are two patients. There are women who are at risk of childbirth complications, and maybe I could just highlight a few. Women who, for instance, have had blood pressure during the pregnancy, women who've had diabetes during the pregnancy, women who have twins or triplets or quadruplets, women who have delivered more than 5 children, and women who have had a prior history of a complicated delivery or a childbirth complication. So these are women who are at high risk, and ideally they should be monitored more keenly. And during the labor process, assessment should be done from time to time to confirm that the mother is okay. There are babies who, for one reason or the other, might have, we call them still babies in utero, the fetuses could have a risk. For one reason or the other, maybe the baby was not growing properly, or maybe the mother is diabetic, and we expect that the baby may not have been growing normally. So these babies should also be monitored. Usually there are machines and gadgets we use to confirm that the baby is responding well to the stress of labor. So there are two patients. There is a baby and there is a mother, and both of them ideally should be monitored for us to be able to detect any potential complications and then decide on what intervention should be done. Some of the potential complications for the mother during the labor, the word complication might look very difficult a term, but we're simply saying maybe the labor is, as Dr. Sang has elaborated, too short, that the labor has progressed very fast, or it is taking too long, such that despite the regular uterine contractions and pain coming, the cervix is not opening the way it should. Or for one reason or the other, the cervix does not open at all, when you're trying to give the medication to try and cause the cervix to open. For the baby, sometimes you might discover that instead of the baby coming head first, comes with either the legs or the arm. That is termed as a complication, and there are interventions that need to be taken. Occasionally, you might find that the baby might be, bigger than what you expect, and relative to the size of the mother's pelvis, the baby cannot come down, or might get arrested at either the first stage of labor or the second stage of labor. So basically what we would define is anything that deviates from the expected would be considered a potential complication, and their interventions are put in place. Some of them are surgical, others are non-surgical.
And Dr. Sang, basically, if I may ask, the causes for these complications, are they the same as the risk factors that Dr. Muruki has highlighted, or do we have more causes for complications, especially when he talks about instead of the head first for a child, it's the legs first? What could be the causes for that?
Yeah, these are things which we probably have noted during the pregnancy, as the lady comes for antenatal care. So if we've realized that the head is facing up or it's a breech presentation, then we generally nowadays prefer to do a cesarean section. Unless a mother just comes into the labor ward with the legs hanging out, then you may have to try and deliver vaginally at that stage. Also, a lady who has had a previous cesarean section is at risk of a rupture. That uterus is not as strong as it would be without the cesarean section scar. And so this lady has to be monitored very well if she wants to try and deliver vaginally after a previous cesarean section. Because should we notice that that scar looks like it's going to give way, then we have to rush her to theater. So there are some deliveries which should not be attempted in a facility which does not have facilities for cesarean section. Also, monitoring the baby is very important because, again, after the whole process of labor, we don't want a baby who is going to come out distressed and needs to be taken to the ICU or even can die during the labor process. And if we notice that the baby is getting stressed, then we have to do a cesarean section to save the baby's life.
All right.
Yeah.
Okay, keep talking to us. The number is 0791478990. We are live. Call us and ask us a few questions. How are you able to tell that you might have childbirth complications, and how do we correct that? These are the questions we'll be answering. But feel free to call us and ask your own questions that you feel we've not talked about right here. Use the hashtag #MyDoctor to speak to us on Twitter at Ebru TV Kenya and at Purity_Museo. And Doc, there's one of our viewers who is asking, you've mentioned something about a baby being stressed, and now you have to deliver fast to just save the baby. So they are asking what leads to a baby getting stressed while at the womb?
Labor itself is a stressful situation because during a contraction, when the uterus is hard, the blood supply to the baby stops for a few seconds. And some babies will tolerate it very well, but others do not have that ability to tolerate that stress. And so their heartbeat pattern is going to show. Either it's going to be too fast or too slow. And so we do monitor the heartbeat of the baby. Others are, as Dr. Muriuki said, some are diabetic mothers. The baby may be too big. Others have had high blood pressure, so the baby may even be small, has not grown well, and so already is at a disadvantage. And so this extra stress of labor may not be tolerated well.
All right. So this is a baby who is not really okay. Maybe they are too big or too small.
Exactly.
Then they will not be able to tolerate the labor, so they get stressed.
Exactly.
All right, well explained. Now, you also mentioned something to do with some of the possible causes. Now, when, for example, a mother comes for antenatal care and you realized that the baby is not well positioned. But just before I pose that question, we have Beatrice on phone. Hello, Beatrice.
At work.
Yes, Beatrice.
I'm 29 weeks pregnant. I wanted to know the complications that I'm going to face.
Right.
Especially now that I'm in a process where the labor is too much. The stress, what not to do, what to do. Yeah.
Okay. Thank you so much, Beatrice. I don't know whether you've heard her question.
I think
she's 29 weeks, and yes, and she's saying the labor is too much. You just want to know whether there are some complications she's looking forward to having.
Yeah. So I think I would not start that and say that she's, we would say that she's at 29 weeks. Ideally, if she's in labor right now, then that is not good, because that would be termed as preterm labor. But what I think she seems to be highlighting is that she wants to know what are potential complications that she would get when her labor comes in. First, I want to say that Beatrice, I mean, pregnancy is, we say 85% of women would actually get pregnant and proceed to deliver without any complications. So that we don't start on the norm that every woman gets a complications. Majority have a straightforward normal labor and a normal delivery. So I would start on the premise that it's good to assume that she will get a normal labor without any complications. That said, I think there's always anxiety towards the end of pregnancy for most women, especially first-time mothers. They might not know what to expect, what to anticipate. And sometimes it's good to, at least maybe during the 36 weeks visit, to have a discussion with the doctor, get to know what to anticipate, and what interventions might be done if there is any potential complication. But usually it's very difficult to elaborate and project. We usually say, if the labor is handled by a competent healthcare provider, they will be able to detect and be able to communicate with the mother about whatever issue that is deviating from the normal and be able to address it.
Yeah. Yes. And maybe you would help them understand what to expect during delivery, if you don't mind.
So what we usually would say first is that labor has never changed, much as, you know, we live in a microwave generation where you put something in the microwave and 5 minutes it's already out and warm.
Yes.
For labor, we know that it starts slowly. And there's a latent phase where there might be some pains on and off, but the cervix is not opening up. And then there's what we call the active phase of labor, as Dr. Sang elaborated, that we expect that the cervix should be opening at a minimum 1 centimeter per hour. So there is pain, because labor is a painful process. How do we handle pain? And those are the issues that we should be able to address, because some people fear pain.
Yeah.
Okay, and pain is not a good, it's not a good thing, but we know that there are ways to manage the pain. Some of them actually don't require any medication. Sometimes what a woman needs is a support, either a close family member or what we call doulas, who can be able to support and work with these women during the labor process. So we anticipate that there will be pain during the labor process, and how do we handle the pain is one of the things that we would ideally be able to discuss with them in the clinic. So with the labor process going on, as labor advances, sometimes you might notice that, yes, the pain gets a bit more intense, the contractions last longer, the intensity is usually higher, the duration in between the contractions is shorter. So we would ideally be anticipating that as the labor progresses, the pain becomes more intense. But again, that's the way the labor process is. Yes.
All right. And just before Beatrice called, Dr. Sang was asking you, you said that sometimes the positioning of the child, what affects the normal positioning of the child in the womb?
Various factors. Usually the head faces down towards the end of pregnancy. And the main reason is that at that time, the head is actually the smaller part of the baby and faces down where the uterus is a bit narrow. And the buttocks or the breech is usually on the wider part of the uterus, so facing up. Certain situations can make that process different. For example, if the cord of the baby is a bit short, then the baby may not be able to move around well in the uterus, and so gets caught facing with the head up. Also, if the placenta is low down in the way of the baby, then again that may interfere with the movement of the baby. Also, the uterus may not be the normal uterus that we expect. Some ladies have a uterus which has an abnormal shape, where it's not the usual round, bigger on the top. And so again, that may interfere with the positioning of the baby. And twins, again, because again of the less space, then with twins we sometimes get that one twin is either facing up or sideways. So those are the issues that we see with the position. But we should be able to determine that before the labor starts, because now we try and avoid delivering a baby who is not coming head first, because again that is prone to complications. Because, for example, if the legs come out, then at times the head can get stuck and the baby will start breathing, and again that would be a problem for the baby.
Yeah, and Charles, do we see some complications just during delivery? Because some, as Dr. Sang is saying, they can be detected during the antenatal clinics, but are there some complications? Let's talk about excessive bleeding that just happen during delivery, and how as doctors are you able to really correct that? How are you able to know that this lady might have more complications during delivery, though they have not expressed just before they could go into labor?
Yes, so it's important to highlight, yes, that bleeding can happen during the labor process, before labor actually, during the labor process, or even after delivery. And the bleeding, usually we categorize it before the delivery, is called antepartum, before delivery. And this type of bleeding is usually, most of the time, associated with the placenta. So sometimes you might get a history in the patient that might point to that risk. For instance, if during the follow-up in the clinic, the scan was done and confirmed that the placenta was low, or if, for instance, they've had the issue of blood pressure, that could also trigger bleeding before delivery. There are other factors like smoking, using of other medications that can also be associated with that, or if the patient has had that history. So bleeding before labor is considered as a complication. Bleeding during labor is also considered as a complication. The only challenge now is, as we said, there are two patients, and most of the times when bleeding happens, we have to try and ensure that the mother is stable and also try and save the life of the baby. Sometimes women who have delivered many or more than 5 children, usually at a risk of also bleeding, but this is usually after delivery. So any woman who delivers is at risk of bleeding complications, and especially after delivery. So that is why routinely all women who, after delivery, are given an injection to ensure that the uterus contracts and the bleeding is reduced. So it is important that wherever a woman delivers, that there has to be a competent healthcare worker, a skilled birth attendant to be able to deliver this mother and deliver the placenta and confirm that the bleeding is not heavy.
All right. And when we come back, we have a look at what are some of the signs and signals during pregnancy that may highlight or show that a mother-to-be is likely to have some of the childbirth complications, and treating the childbirth complications. How do we save the lives of both the mother-to-be and the child? Those are the questions we'll be answering when we come back after this short break. Remember, the number to use to call us live is 0791478990. Stay tuned. Welcome back to the second and the last part of the show. Just in case you're joining us for the very first time, we are talking matters childbirth complications. We are looking at who is at a risk of getting some of these complications. What are these complications that affect the mother-to-be and the child? Most importantly, how do we correct them? How do you tell that you are going to have these complications, and can you still deliver safely while you are having them? What are some of the management process for the childbirth complications? Keep talking to us. Call us live. The number is 0791478990. Just to remind you, it's the second and the last part of the show. You do not want to miss out on this. Asking the special guest, we have the questions of your concern. Talk to us on Twitter at Ebru TV Kenya and at Purity_Museo. Use the hashtag #MyDoctor, and help me welcome once again my guest, Dr. Charles Muriuki and Edward Sang. Thank you for staying with us. Welcome to the second part of the show. Thank you. Yes, and while we were on our break, there's someone who was asking the issue of cesarean section. They want to know if, for example, you've had one, after how long should you opt to have another if you do not want to go through the labor process, and also the issue of high blood pressure.
Cesarean section, if somebody has gone through one, in the past we used to say maybe stay 2 years or 5 years after the cesarean before getting pregnant again. But right now, I don't think that you really have to wait long. When you're ready for another baby, you can go ahead and get pregnant. And then during your antenatal clinic, you'll discuss with your doctor options of repeat cesarean section or what is called vaginal birth after cesarean section, because that is still possible.
Yeah.
Where a lady has had cesarean section, but she opts for a normal delivery, and that can be, as long as everything is okay, it can be done with a success rate of about 70%. So the duration now is not a big issue. As far as preeclampsia or high blood pressure is concerned, it's a very common complication and can be quite dangerous, to the extent that if it starts very early in pregnancy, it's a reason to actually terminate the pregnancy because of the sake of the mother. Yeah. It's very dangerous for the mother, and would also lead us to deliver early if the baby is not yet mature, in other words, premature. At times we have to deliver the baby because the blood pressure does cause complications to the mother, like convulsions, what we call eclampsia. The mother can get renal failure or liver failure, and so it's a dangerous complication that at times warrants us to deliver the baby because it's caused by the pregnancy, and once the lady has been delivered, then that problem settles. And so at times we have to do delivery as form of treatment.
Yeah, and let's go back, to, Doc, to cesarean section. Some people believe that it's not a better option for delivery. Others just say, I just have to go through this. What are some of the reasons that doctors can advise that, you know what, it's high time you go for a cesarean section? Most mothers want that option. Others are afraid of it. And once you're told you cannot deliver normally, then it's stigma. You feel that you're not really, you know, an ideal or a real woman. So is it a good option for delivery? And when you compare to normal delivery, are there some of the cons, you know, advantages, merits and demerits of the cesarean section?
Yeah, it's an interesting issue. Which is better? Is it normal delivery or cesarean section? Each has its advantages and disadvantages. And cesarean section in certain situations is life-saving and is a must. For example, in a lady who has had a previous cesarean section, whose uterus is giving way and opening up, then it's life-saving. The lady has to be taken for cesarean section. Also, if the labor has taken too long, you can lose the baby and you can have severe injuries to the mother. So again, cesarean section is very important. Then there are those ladies who have no problem, no complication, but they would prefer to deliver by cesarean section because of the pain. Some just fear the pain, as Dr. Muriuki was saying, and they don't want to go through labor and all that pain, and they just want to go to theater, fall asleep, and wake up with a baby. So it's a debate that will always go on, but I think a lady should be able to choose and should be given the options, the advantages and disadvantages. Normal delivery, if it's done well, is okay, but also can have complications. For example, for breech delivery, it's not very safe and can cause harm to the baby and to the mother. Also, long-term effects. The one disadvantage of normal delivery is that with the baby passing through the birth canal and causing a lot of stretching, this stretching affects the tissues around the vagina. And this will come back later in some women to haunt them after menopause, because now the tissues start getting weak and sagging, and then they'll have various, even the uterus can come down, the bladder and the rectum may fall into the vagina, causing a lot of discomfort. And this can be traced back to the normal delivery that they had, which a lady who has had cesarean sections only will not have. Yeah.
Okay, and Dr. Muriuki kindly help this viewer who is asking that she was about 40 weeks pregnant and she had a miscarriage at 40 weeks, and now she has low blood pressure, and again to add on that, she was told she cannot deliver, she cannot have a baby anymore, she cannot get pregnant anymore. What could be the problem?
Okay, I think what we'd say is that at 40 weeks, we'll not call it a miscarriage, probably would call it a stillbirth.
A stillbirth.
So we probably need to have a discussion with such a patient. They need to see the doctor and get to know what caused the stillbirth. Was it the blood pressure being high? Did she have, and those are risks that were there during the pregnancy that probably were not picked up. Did she have diabetes or even gestational diabetes? Mainly diabetes is what would cause that as opposed to gestational diabetes. Could there be an incident that might have caused the placentas to stop functioning well? And some people might have had such risk factors. However, it's also important to highlight that most of the stillbirths, actually, you might not find an exact cause. But I will not be quick to say that they should not try again for pregnancy, because I think it's very difficult to tell a woman who might not necessarily have had an event that was life-threatening to her not to try again for pregnancy. So I think it would be good to have that discussion with the doctor to know what caused it. Is it likely to happen again? If she wanted to try again for pregnancy, what does she need to do to prevent or reduce that risk?
And once again, she was informed that she cannot get pregnant. Is it related to the stillbirth she had, or what are some of the possible causes for that?
Again, as I was saying, I would not recommend to say, I wouldn't recommend such outright blanket comments that, you know, she should not get pregnant again.
Yeah.
There has to be maybe a reason why the doctor would recommend that. But ideally, an event that was not life-threatening to the mother should not be reason to tell a woman that she should not try again for pregnancy. If at all the event was life-threatening to the mother, in the sense that, you know, and it's something that is persistent, that cannot be reversed, then that is when we would consider that maybe we would advise. For instance, patients who have had maybe liver complications or kidney complications, they're on dialysis, we probably will look at it and say pregnancy is a risk in itself to her life, so we would not recommend her to get pregnant. So I think I would probably say there is a lot more information that we do not have that we might need to get to be able to offer a professional advice in terms of whether she should try for pregnancy or not.
Yeah. All right. And Dr. Sang, help us revisit the issue of who is at a risk. What are some of the complications or diseases that once a mother to be, when you are pregnant or when you are preparing to get pregnant, once you suffer these conditions, then you are at a risk of having some complications during delivery?
One example is anemia, where the lady's blood level is low. The commonest cause of death, because pregnancy does cause death, both for the mother and the baby. And we do lose a number of patients as a result of pregnancy. So bleeding is the #1 cause, either during pregnancy or after delivery, and mainly after delivery. So if a lady is noted to have excessive bleeding after delivery, then that really warrants close attention. And some even need surgery. Some need blood transfusion. Some need dialysis, as Dr. Sari was saying, for issues of the kidney. Yeah, so pregnancy is something that really needs to be monitored well. To deliver in a facility which can offer emergency services, and or a place where a patient can be transferred to a facility which can manage the complications. Yeah.
All right. And other than having suffered these complications, Dr. Muriuki, are there some signs while you're pregnant? Are there some signals? Let's say, I know pain is one of it, but do we have some other signs that a mother, once you begin having these signs, then you really need to take care of, you really need to go and see a doctor because there are signals for a complication during delivery?
Yeah, so there are signs we call danger signs during pregnancy. And these are signs that we communicate to any pregnant mother, whether it's their first time or not. And usually we highlight, especially if a woman notices if there's any pain, especially in the lower abdomen, and especially if it's going to the back on and off, it could be labor. If at all they see any bleeding, whether it's during the pregnancy period, during the labor, or even after, that is a concern or a warning sign. If at all water breaks before time, you know, and sometimes that water breaking before time can potentiate on or increase the risk of the cord coming before the baby, and that is actually one of the another childbirth complication. If the cord comes before the baby, then that's an emergency. It's called a cord prolapse. If at all the mother reports having headaches, especially on the front, sometimes that could be associated with a blood pressure issue, the blood pressure being elevated. Sometimes they might also notice they're not able to see clearly, what is called a blood vision. Sometimes they might notice that they say they're seeing almost like double, which is again associated with a blood pressure issue. Sometimes they may notice that they have a very bad heartburn, you know, and that again is also a danger sign. If they notice that there is a swelling on the leg, or if there is pain in the leg or pain in the chest, that could be a blood a clot either in the leg or in the chest. So it's important not to ignore small subtle signs. Sometimes actually seeing the doctor early enough would be able to alleviate any potential risk to the mother or to the baby. But again, it's also important to know that a woman might not have any problem, but during the labor process, something might change and put this lady at a high risk. For instance, when the baby is coming out, sometimes you might notice that the baby is bigger than the passage, the mother's passage or the birth canal. And that can sometimes make the delivery complicated. Sometimes we call it shoulder dystocia, where the shoulders of the baby are not able to be delivered. For instance, during delivery of a baby, maybe of a mother who had diabetes, that baby can be big and might cause some vaginal tears. Some are significant because they might require to, to be repaired or stitched up in theater, because they might damage the canal through which the stool comes through. So these complications can happen. Some you might be able to preempt them, others you are unable to preempt them. But again, the bottom line is I'd want to highlight is that 85% of women will have a normal pregnancy and a normal delivery without any complications.
Right. And Dr. Sang, the lady that was saying that she was at 40 weeks and she unfortunately had a stillbirth, is back. And she's saying that actually the doctor did not tell her not to try getting pregnant, but the doctor said she cannot get pregnant even if she tried. And she's also coughing some blood. Maybe she wants to understand what is the problem, why can't she get pregnant, does it have anything to do with the stillbirth, and why as well is she having these complications, bleedings and all that after the stillbirth. Kindly help her.
Yeah, I think the information still is not adequate, because as long as the uterus was not removed, which at times we do for severe bleeding, for example, then the lady should still be able to get pregnant.
Maybe you can give her your contact.
Yeah, so she can be in touch.
So that she can be able in touch and come for examination.
Yeah, so I think she can be in touch with the station and maybe get in touch with us.
Yeah, if they can get in touch with you, you can just go ahead and give her, because it's a real concern.
Okay, I could just give my number,
yes.
0723 114160.
Yeah.
Then she can be in touch, then we can look at the specific aspects.
Repeat the number for us.
0723 114160.
All right, and also Dr. Muruki, just try also giving her your number as well.
Yeah, my number is 0733 287845. That's 0733 287845.
Right, just try getting in touch with the experts, the number they have given you for further examinations, so that you can try and get help. Keep talking to us. Our topic of discussion is stillbirth. We are looking at some of the possible complications for both the mother-to-be and the child. Use the number 0791478990. We are still live and ready to receive your questions, your comments, and your concerns. Now, you had earlier on highlighted some of the possible complications or the signs, the danger signs during pregnancy for a childbirth complications. Now, once these complications occur, Dr. Sang, how do we correct them? What are some of the treatment options, for example, for a woman with high blood pressure, excessive bleeding, wrong labor contractions? How do you correct that?
Yeah, so for the bleeding, which is the most common cause of death, so if we're in a situation where the lady's life is in danger and we're in danger of losing her, and we do lose a number of patients around this country because of bleeding, most of the time we'd want to examine her in theater and see what is the cause of where is the bleeding coming from? Is it a tear? Is the cervix injured? Or is it because the uterus is refusing to contract? And most of the time the bleeding is coming from the uterus. So one of the interventions which we do use is to actually remove the uterus at that time. And of course this will make the lady unable to get pregnant again. So it's not a decision we take lightly. And so we only do it when we feel the lady's life is in danger. At most of the time, again, at this time we are giving blood transfusions. So hopefully we have blood in the hospital that we are. And so something, again, to appeal to people to donate blood whenever they can. The other thing we do is use certain medications to try and help the uterus contract. Sometimes we have to stitch places which are bleeding, tears and things like that. For the high blood pressure, which again is quite common, is to use mainly medications. And if it's too severe, then we have to deliver the baby.
And are there some complications that are not able, unfortunately, to be corrected, and the only option, like you said, is doing away with the uterus?
It's mainly the bleeding.
All right.
It's the only reason why we remove the uterus. Blood clots, again, are quite dangerous. At times, unfortunately, there's not too much we can do if it's sudden and causes, when a clot goes all the way to the lung and causes breathing problems. At times, we'd take the lady to ICU, and if the ICU is probably the only place where she can be treated with certain medications to break down the clot. So those are some of the issues we deal with.
And Doc, when you talk about removing the uterus and this person is pregnant, where is the baby at this particular point?
Sorry, this is actually after the delivery.
Oh, all right.
So the lady has delivered, and then suddenly there should be a little bleeding, but again, these should be within normal parameters. If it's a normal delivery, it should not be more than ½ liter. If it's a cesarean section, it should not be more than 1 liter. So if the bleeding continues, you start seeing the blood pressure is dropping, the pulse rate is going high, then we are worried that now the lady's life is in danger. Then that's when we would start to intervene.
All right, thank you so much for that. And Dr. Muruki, allow me to ask you, is there a way we can prevent these childbirth complications from occurring? Do we have some preventive measures that you can advise, maybe for mothers at home?
Yes. So I think there are risks that we can quantify, and there are risks that we cannot quite avoid. You know, pregnancy complications result from pregnancy. And we cannot say do not get pregnant. You know, most women would want to get pregnant. What we usually say, I mean, there was a common saying in Tanzania, and at one point it was highlighted as a reflection of the situation in Africa, where a woman would say getting pregnant is almost like going on a journey and not knowing whether they will come back. And that is a sad state, because ideally pregnancy should not be a scary thing. What we would say is that once a woman gets pregnant, they should at least be able to access antenatal care and antenatal services. They should be able to be assessed at the initial visit, and during the pregnancy be able to say, is this woman having a low-risk pregnancy or a high-risk pregnancy? If a patient is having a high-risk pregnancy, we usually recommend that they should be able to see a doctor, and if possible a gynecologist, so that they can be able to know, how do we mitigate this risk? How do we handle the pregnancy and delivery to reduce the risk to manageable levels? Sometimes you cannot be able to eliminate that risk. So that is why we emphasize, if possible, delivery should be done in a hospital with a skilled birth attendant who is able to not only identify risks during the labor process and during delivery, but be able to know when to intervene and what to do. For instance, bleeding is, as Dr. Sang highlighted, the commonest cause of maternal deaths in our country. And any skilled birth attendant should be able to know how to deliver the placenta, the medications to give to reduce the risk of bleeding, and be able to also know when to have a doctor come in and do any further interventions that are necessary. So there are risks that we can be able to reduce. There are others that we are not able to reduce, because they purely come because of a woman being pregnant. Yes.
All right, and you've mentioned the one that could be reduced. Now, Dr. Sang, allow me to take you back. For women who've had a history of miscarriages, and also let's talk of clinical abortions for some various reasons, should they worry about, let's say they are now pregnant or they're thinking of getting pregnant, should they worry about having some of these childbirth complications that may occur?
Well, miscarriage can recur. So that is, we have to look out for that. Some are preventable. For example, some ladies have a miscarriage because the cervix opens up too early, because it's maybe weak or too short, for example. So those can be treated by, we tie the cervix with a stitch so that it holds the pregnancy until time for delivery. So some can be prevented. Others may not be prevented. For example, if it is a chromosomal problem, that may not be prevented. But fortunately, they don't recur much. So if a lady has had a miscarriage, we always encourage them to try again. And many times the pregnancy now goes well.
All right, and one of our callers is asking, she asked in Swahili, I'll try to translate it, but she's 2 weeks pregnant, 2 weeks pregnant, but when she went maybe for some checkup, she was told, do we have at some point whereby your uterus is termed dirty and you need some cleansing? You know, that's what she was told, and now she's wondering whether it's going to affect the baby or what is going to happen.
So I think it's important to first and foremost know if she is pregnant, how many weeks, and confirm how many weeks.
She tells me
pregnant.
she's 1 month, 2 weeks pregnant. Sorry.
She's 6 weeks pregnant.
Yes.
So what we need to know is at 6 weeks pregnancy, is a pregnancy inside the uterus or out of the uterus? And if the pregnancy is inside the uterus, are they able to see the baby, and are they able to pick up the baby's heartbeat? If for one reason or the other, they are not able to pick up the baby's heartbeat and she's not bleeding and she's not having any pain, then ideally would recommend waiting a bit more to be able to do another scan again. And I'm assuming she's had a scan. Ideally would recommend that a scan should be done to confirm that the pregnancy is ongoing or not. There are certain parameters that we use to decide cutoffs in terms of knowing whether this is pregnancy that is ongoing or unfortunately she might have had a miscarriage. So maybe what they're not able to do is communicate effectively to know that maybe what they are suggesting is that there could be a possibility of a miscarriage, and that's why they need to clean up the uterus. What is called a suction evacuation basically is to remove the material that is inside the uterus. This ideally is done for women who have had a miscarriage, but before you quantify and qualify that this is a miscarriage, the best sometimes is to seek a second opinion and have to see, is this cutoff actually correct before somebody quickly says that, you know, there's a miscarriage. Yes.
And so if at all it happens, if she follows the doctor's advice and it happens, definitely it's going to affect the baby, right? So
we would not recommend cleaning up the uterus
right,
if a woman is pregnant, because that is essentially terminating a pregnancy.
Yeah, yes. All right. That's what she needs to understand. All right, and my director tells me it's time now to wind up, in just in case you have a few tips that you can give women out there, especially those who are pregnant, to just stay safe, you know, to just avoid, if there are some tips or some ways that they can minimize the chances of getting these childbirth complications, then it's high time that Dr. Sang, you just help them with that. And also, once again, just to repeat how we can reach to you.
Oh, yes. I'd given my number, 0723 114160. I think the main thing is antenatal care, so that we are able to look out for any problem before it occurs. Nowadays, there are also apps online that patients can get and can follow their pregnancy day by day, and even have more information about how the pregnancy is growing, and for anything that is unusual that they may need to ask their doctor about. And so those are available. And then deliver in a hospital with good facilities for emergencies. And then when you've delivered, then to use family planning to prevent a pregnancy until you're ready for another one, so that you don't get an unplanned pregnancy. All right.
Let's get to see how we can reach you once again, Dr. Muriuki.
Yeah, so my contact is 0733 287845. Just to re-emphasize what Dr. Sang said, I don't think I would put it much better, but antenatal care is important. And especially for women who probably have delivered before and they probably think they have the experience and they're experts at it. Actually, sometimes they are the women who are at a higher risk of childbirth complications. Usually in the clinic, tests will be done, and if at all there is any deficiency, they might need iron supplementation or things like that. And the follow-up in the clinic ideally would be able to be, in a sense, in a manner that would pick up any potential complications that might occur that can affect the delivery. If possible, the woman should be able to deliver in a facility that can be able to take care of both her and the baby.
Right.
and if at all there are any potential complications, that they can be addressed.
All right, Dr. Charles Muriuki and Edward Sang, thank you so much for coming. That's all the time we had for the show. It was quite informative. Personally, I've learned a lot, and I know our viewers have also learned quite a lot. Thank you so much. Looking forward to hosting you once again on the show.
Thank you very much.
Yes, and thank you so much for your feedback. That's the end of the show. But remember, My Doctor Show comes your way every Monday, Tuesday, and Wednesday, 10 a.m. to 11 a.m. You can always download our previous episodes, any of your choice, from our YouTube channel. Simply go to the YouTube Ebru TV Kenya and Purity Museo and choose the episode of your choice. Once again, I'm Purity Museo. Thank you so much for watching. Goodbye.